Okay, so today I will be presenting on one of the cases that I saw when I was a trainee here at IJR. And so to give some context, as Dr. Adil mentioned, I've been working with Dr. Adil in the Disruptive Behaviors Clinic and then the Urban Youth Trauma Center and Strong Families for the past, yes, 10 years now. And with Strong Families, I have a unique experience in that I've helped with some of the adaptations and research side of Strong Families, but then I was also a extern in the clinic for 2 years, implementing Strong Families with some of our patients that we see. And so I thought it would be a really good idea today to spend a pretty large amount of our time going over a detailed case example so that you all can see kind of how this looks within a clinic-based setting, within an academic medical center. And then also just the importance of being able to complete manualized interventions, even for some of our most complex cases and our kids that have co-occurring issues. So today I will be presenting a case on an 11-year-old who I'll refer to as Camilla, and I've identified the 8 areas here that we'll focus on for the case. Okay, next slide, please. Okay, so first I'll start with the brief case introduction to tell you all about some of the key problems that Camilla presented with at the start of treatment. And then if you have questions throughout, I want this to be a discussion, so you can put those in the chat. And then Dr. Dill, maybe you can just let me know if you see any questions. So first, just giving kind of an introduction to the case, Camilla was an 11-year-old Latina female who was admitted to the Strong Families treatment program following reports from her mom that she was exhibiting disruptive and defiant behavior at home and school. At the time of intake, Camilla was also experiencing significant traumatic stress reactions in response to her mom's chronic health condition, which I'll talk about a little later. Camilla also had a history of community violence exposure. And when I gathered this information at the start of treatment, it was important to get information about the frequency, duration, and severity of these symptoms and issues that mom was reporting. So Camilla's mom reported that the maladaptive and defiant behavior had been present for the past 2 to 3 years. And mom also reported that when Camilla became upset, she tended to express her anger or disapproval by yelling, using profanity, and then most recently, she was also hitting mom when she became really upset. Camilla's dad also lived in the home and she was not physical with her dad. However, the defiant behavior had also become present in their interactions. And then with school, she was also having difficulties with her temper and constant disagreement with teachers. So those are some of the key presenting problems to keep in mind. Okay, we'll go to the next slide and look at some of the history. Okay, so I've kind of separated this into 4 different sections so you all can get an idea about the detailed history that we get for all of our kids that come into the Strong Families Clinic. And so we want to get a comprehensive history across these 4 different areas. First, starting with medical and developmental history. So Camilla's mom mentioned that she had experienced renal failure during pregnancy, which prompted an early delivery at 27 weeks. And Camilla was in the hospital for 4.5 months following birth. When Camilla was a toddler, her mom was told that she had cerebral palsy with primary deficits related to joint movement and difficulty with her right leg. During the intake assessment, Camilla reported no significant discomfort or challenges related to the cerebral palsy. However, she did note that she sometimes had extensive pain in her leg during high physical activities at school, such as gym or any other exercise that they would have to do. And so we later found out that that was linked to a lot of the anger and hostility that she would experience throughout school. And so just a quick note, over the course of treatment, I was able to work with Camilla's family and some of the specialists at UIC to get her enrolled in physical therapy and then also pain management. And then back to developmental history, mom reported that Camilla had some delays in meeting basic developmental milestones, noting that Camilla was late at walking and toilet training. However, there were no significant language delays during early childhood. Camilla's temperament was described as kind of pretty easy and warm during birth and early childhood, but mom noted a significant change in her temperament as time progressed going into late childhood. So next we want to gather information about academic functioning and school behavior. So one of the key components of the Strong Families intervention in modules 4 is looking at behavior, not only within the home, but also within a school-based setting. So Camilla was in the 6th grade at the time of treatment, and she had an IEP. She was participating in regular and special education classes with accommodations for reading, writing, math, and science. According to mom, Camilla often refused to do her work and had difficulty concentrating or retaining attention while she was in class. We always look at kind of grades and report cards when kids come in for intakes. Camilla had an average of around A to D, with some of her higher grades being in the extracurricular activities or classes. Camilla was also currently reading at a 4th grade level. So even with the accommodations that were in place, she was performing below average. According to mom and Camilla's primary teacher, Camilla had pretty good relationships with peers, but that was only if they were listening to her or agreed to what she wanted them to do. Mom reported that Camilla often wanted to be the boss or be in charge when she was at school, which was the start of some of her recent trouble with other students. A review of Camilla's previous school records revealed that past teachers had also noted issues pertaining to Camilla's bossy attitude, as they described it, or her having an angry or defiant mood when she was at school. Next, we want to do an evaluation of past mental health treatment. So Camilla did not have really an exhaustive medical record or psychiatric record like some of our kids may have. She had an evaluation completed at age 9. However, there were no significant issues noted. And so a detailed evaluation was not done. And she had not participated in any type of therapeutic services prior to coming to our clinic. At the start of treatment, she was also not taking any medication and had not taken any type of psychiatric medication in the past. Last, we always gather extensive history regarding the family, not only because our intervention is family-based, but because we know that parents have such a significant role in helping with behavior modification and trauma recovery. So as I mentioned, Camilla was living with both of her parents, mom and dad, and she also had an older brother who was living in the home. Mom was unemployed due to her medical disability, and dad worked a night shift position at an industrial facility. And although dad was at home during the day, he was usually asleep to prepare for work. And so that often made mom the primary caretaker and disciplinarian. And Camilla's 18-year-old brother was currently enrolled in college, and so he was rarely at home. Mom reported no family history for psychiatric diagnosis or previous alcohol or substance addiction. And it's important to note, which was kind of the main focus of this case, was that mom had an extensive medical history and ongoing challenges throughout the course of treatment. So mom's medical procedures and illnesses prior to Camilla coming to the Strong Families Clinic included renal failure during pregnancy. And then as Camilla got older, mom had a kidney transplant and heart operation. She also had arthritis, high blood pressure, and diabetes. And so there were a lot of health challenges that mom was experiencing throughout the course of treatment, as well as often having to go to the doctor for appointments. Throughout treatment and even at intake, Camilla expressed significant concern about mom's well-being and concerns about what would happen if she became really sick. Throughout treatment, there were no concerns regarding dad's health mentioned by the family. Okay, we'll go to the next slide and talk about some of the assessment that we do.
And Linda, a quick comment. I just want to appreciate all the things going on in this young woman's life. Mm-hmm. But the problem that we'll often hear is they're just bad, just bad behavior. And I think there might be one comment, Yvonne, if you want to chime in quick as we go to the next slide.
Oh, no, I was going to wait until she got to the second part to speak.
Okay.
Okay. Yeah, that's a really good point that Dr. Dill made. Even when we had the initial referral from the school regarding problem behavior, and during that initial call with mom, there was no mention of all the other family challenges that was going on and the significant health challenges that mom was experiencing. It really focused all on kind of Camilla's bad behavior at home and at school. So next is the assessment. So within Strong Families, in our clinics at UITC, we have a pretty comprehensive assessment packet that we have families complete at baseline and then also throughout the course of treatment so that we can have a pretty good understanding about what the clinical concerns are, and then so we can have a way to monitor and track treatment progress and symptoms. So first with Camilla, I wanted to assess her emotional, behavioral, and psychological functioning. And so you'll see here the different assessment scales that we utilize within the Strong Families Clinic. And I'll give you just a brief overview of kind of where Camilla was at across some of those key scales. And the reason I'll cover those is because the results of those, as well as the clinical interview, usually help to inform our treatment plan. So for Camilla on the Youth Self-Report, she was in the borderline clinical range, and with Mom, she was in the clinical range. And so that's our report that gives us an idea about social and emotional functioning. On the Child Depression Inventory, Camilla did endorse a few cognitive and behavioral signs of depression. However, there was no significant concerns noted there. All scores for Camilla on the trauma symptom checklist were well below the subclinical range. However, we did initial assessments later on, and it seems that Camilla was underreporting symptoms during that initial trauma screening. And then because Strong Families focuses on treatment of community violence exposure, we always assess for children's reported exposure to community violence. And on this measure, both Camilla and her mom reported extensive past exposure to community violence. And in looking at some of the impacts of community violence for Camilla in particular, Mom noted this increased level of hypervigilance in which Camilla often seemed on edge when going in her neighborhood or walking to school. And a lot of this seemed to be connected to frequently hearing gunshots, either while home or while outside. Next, we gather information about parenting and family relationships. So we use the Alabama Parenting Questionnaire and the Family Relationship Scale. On the Alabama Parenting Questionnaire, which was completed by both Camilla and her mom, they were pretty in sync in terms of what was reported. They both reported that Mom was pretty involved in Camilla's life, that she was, even though she was often feeling sick, she was very active in the things that Camilla would do in school. And so there were no significant issues noted there. The one area where we did see them score lower was in the subscale that looks at consistent discipline practices. And so this was extremely important as we would get into the modules related to behavior management and modification. And so even though Camilla's mom would put kind of discipline practices in place or have consequences for misbehavior, she wouldn't really follow through with it, or she would let her get off punishment early. And so that's where we would see them struggle with the effectiveness of discipline plans. And then in the family relationship scale, both Camilla and her mom completed this measure as well. And they endorsed all of the items about spending a lot of time together between Mom and Camilla. Where we saw Mom endorse more items was related to family-related stress, and that appeared to be related to Camilla's behavior, and then also Mom having to be the primary caretaker at home while Dad was asleep or at work. And then because so much of the family, Strong Families intervention does include the caregiver, we also want to gather information about the caregiver's mental health and well-being. And so we usually use the stress index for parents of adolescents and the brief symptom inventory. And so I'll just talk briefly about the brief symptom inventory. On this scale that Mom completed, within the Global Severity Index, her score was clinically significant, and she was also showing clinical levels of somatization and depression, which these were things that Mom briefly mentioned she was struggling with during that initial clinical interview, but she kind of downplayed the symptoms. And so we did a more detailed screening here looking at Mom's mental health and well-being. And then based on the results of this report, we referred Mom to the adult psychiatry clinic here at UIC that could provide additional mental health services for the families or parents of our patients that we were seeing in the clinic. And then last, looking at an assessment of symptoms and daily functioning. So within our clinic, it's always important to have a way to systematically assess our patient's symptoms and progress throughout the course of treatment. And so we use the weekly reactions, emotions, and behavior scale, which we refer to as the weekly REB, which is a questionnaire that was developed by our team to capture the weekly variations in our patients' emotions, traumatic stress symptoms, and disruptive behavior symptoms. And so I'll show you all at the end of today's presentation kind of what that looked like for Camilla over the course of treatment. Camilla and her mom completed this measure every 2 weeks over a 4-month period. And so we'll get to look at kind of what the symptoms and progress was like for her. And then I won't go into too much detail so we can go on into the next slide, but the mental status exam is pretty important and critical. So in addition to having a standardized assessment, we really prioritize the mental status exam and kind of our clinical observations during that clinical interview and assessment phase. And so some of the key things that were noted with Camilla, no significant areas of concern in terms of observations. However, her body language and tone would often shift or change when she was talking about negative behaviors or when mom was talking about negative behaviors. And oftentimes during those first couple of sessions, she would often defer to mom to answer, especially if she was talking about a negative situation that either occurred at home or at school. Okay, let's see. And the other thing, before we go to the next slide that I want to add, one of the things that we did request for Camilla after one of our interdisciplinary team meetings was the need to have a more comprehensive assessment done to look at Camilla's cognitive functioning, specifically because of her premature birth and some of the other concerns that mom had mentioned. And so in response to that, we contacted Camilla's school so that they could schedule a neuropsychological evaluation. Okay, we'll go to the next slide.
And as we go to the next slide, I just want to, as the kids say today, I just want to pause for a second and appreciate the complexity of the conditions that were brought into treatment and how we use research that you all know. And this is really conversations we have to have with the community. It's like, why are you giving me all these scales and these forms? Is we want to make sense of it with a balance between clinical observations, knowing community context, and using some of these structured scales, which can give us additional insight. So that research to practice bridge is an important part of how we do things, not only in Strong Families, but in the Urban Youth Trauma Center. And communities will say, why am I filling all this stuff out? And you tell them, I'm not just testing hypotheses, I'm trying to make sense of what's happening with you so I can help you. That's why we're doing those.
That's a really, really good point. And you all will see how the different assessment scales that we did during that assessment phase kind of map onto all the different treatment modules that we have within Strong Families. And so one of the things that was really helpful for us is that as we worked on those different modules within Strong Families was going back and pulling out some of those assessments to be able to show the family while we were working on certain skills or strategies. All right, so really quickly going over case conceptualization. So I think because of the complexity of our cases in particular, it's really important to kind of sit down and look at all of the information that we have and then come together and figure out kind of, okay, what's the primary area of concern? How are we going to approach treatment? And what are the different areas that we want to include in our treatment plan? So before going over our treatment plan, I'll kind of give you all an idea of how case conceptualization looks within our clinic based on the information that we have. So just to recap kind of the key points. So at the beginning of treatment, Camilla was an 11-year-old Latina female in the 6th grade attending a public school. Camilla was born prematurely, which resulted in later difficulties, including cerebral palsy and possible cognitive deficits. Her mom reported that Camilla had a history of disruptive and defiant behavior, and due to her mom's chronic health condition and frequent hospitalizations, Camilla was reportedly experiencing significant traumatic stress symptoms. According to her mom, Camilla often seemed unaware of the severity of her negative behavior and was unable to distinguish between parent versus child roles. Mom was seeking treatment to address Camilla's negative behavior and to also improve the family's interaction patterns. Due to Camilla's own early hospitalizations, as well as mom's chronic and declining health status, medical trauma and the likelihood of re-traumatization was noted in our clinic as a key area of concern. The family was also concerned regarding the PTSD symptoms that Camilla was experiencing in response to ongoing community violence exposure. So based on the results of the clinical assessment, the clinical interview, Camilla's history of early childhood trauma exposure, and presenting concerns regarding disruptive behavior in both home and academic settings, there were two key diagnoses that we looked at for Camilla: oppositional defiant disorder, disruptive behavior disorder, and trauma and stress-related disorder. Before I get into the treatment plan, are there any questions or comments about our case conceptualization? Okay. All right. So we'll go to the next slide here. So I'll kind of summarize what you see here. So this is a kind of just a general example of how our treatment plan might look within the Strong Families Clinic. And so for developing the treatment plan, specifically with Camilla and her family, although Dad was not able to attend the assessment appointment, it was very important that both parents were present during the session that focused on treatment planning. And so during the treatment planning session, we generally discuss with families the benefits of participating in treatment, and also looked at the degree to which Camilla's current behaviors were having an impact on social, emotional, and behavioral functioning. And so in addition to focusing kind of only on Camilla, it's really important that we look at the entire family as a whole. And so during the treatment planning phase, we discussed just different family-based components that we want to include within the treatment plan. And so it was decided that Camilla's goals would focus on 5 key areas. So decreasing negative and disruptive behavior at home and school, working on appropriate expression of feelings, practicing use of positive communication and anger management skills with her family, and improving academic performance and school support. And so if you look at the different areas of the treatment plan, you'll notice that we've listed concrete goals here that the family could be able to look at and track over the course of treatment. And we also wanted to make sure that we developed our objectives in a way that we could measure whether or not we were seeing progress throughout the course of treatment. And so if you notice, for example, we have specific numbers for what we want to see change. So if there were 0 positive family interactions, and at the start of treatment, we wanted to reach a goal of having at least 2 to 3 throughout the week. And so having those concrete numbers there were really important and able to have Camilla gain a clear understanding about the goals that she was working toward. And then last here, we have a little bubble about the importance of using a systems of care approach. Within the Strong Families program, we talk a lot about the importance of having multidisciplinary teams and also being in communication and collaboration with all of the different systems that our kids are working with or that their family is working with. And so with Camilla, using a systems of care approach was, I would say, very important. By working in an academic medical center setting here at UIC, where both Camilla and her mom were receiving all of their medical care, we were able to be in communication with their doctors about their well-being and how any of their current health issues might impact treatment or how we could modify treatment based on some of the challenges that they were experiencing. And then likewise, we were in communication with Camilla's school throughout the course of treatment and able to establish an academic plan where we would be in constant communication with her teachers, counselors, and where parents could have a check-in system with the teacher. I see there's a question in the chat. So this is from Sangha. She says she's wondering if I can speak a little about the process of building a therapeutic alliance with Camilla and her family. Yep, thank you for mentioning that. I think we'll cover that in the upcoming slide. That's one of the key things that we do in session 1, the kind of introduction to family therapy and treatment planning, but I'll also talk about it at the end of the session of how there were different cultural factors around the use of mental health services that kind of hindered that initial therapeutic alliance. And so one of the things that's really important is being able to identify not only the challenges that the families are experiencing, but the benefits of therapy. And so it was really helpful in working with Camilla's family to identify how we were all going to work together to make things better, and how working on that therapeutic alliance. And so I think definitely over the course of treatment, we were able to build a pretty good level of rapport with that entire family, because we were able to kind of map out the benefits of therapy, and also how we were working together. And I think one of the other things that was really helpful is that when kids come into our clinic, we really map out the impact of trauma and how it impacts behavior. And so we were able to show all the different things that were contributing to Camilla's behavior, as opposed to just saying this is a bad kid who has all this trouble and it's impacting everyone else. Let's see. So we have another comment here. It says, could you speak more about the decision to add ODD to the diagnosis? If we are conceptualizing that the behaviors are trauma related, would providing a PTSD diagnosis be more sufficient for treatment planning? So within Camilla's diagnosis, we included both co-occurring ODD and PTSD symptoms. And so one of the key reasons for including the ODD diagnosis honestly had to do with some of the disruptive behavior that we were seeing within the school-based setting, the need for accommodations within schools related to 504 plans related to behavior management. And so we talk about a lot with families about kind of diagnosis and labels and what that means in terms of insurance and forms and things like that. It's not a focus of treatment. In treatment, we talk about what are the issues and, what are we going to do to move forward? But I think those are some of the key reasons why those diagnoses were given, just related to, I would say, more kind of systematic or bureaucratic issues.
And all of those are real issues. And on top of that, families and even the kids themselves, real recognize is real. Those are real behavioral issues which emerge. And part of the engagement is we have to acknowledge that there are some behavioral disruptions. There might be some growth in terms of how you understand where they come from, but we can't dismiss gang involvement. You can't dismiss conflicts with caretakers. And our goal is really not to say, I'm going to choose one or the other. We're going to integrate the understanding and the related service to help. And I find that families are a lot more willing to acknowledge that, yes, there is some PTSD, as well as youth are able to acknowledge, yes, some of my behavior is coming to the attention of the system, because it's not the only thing and it's not used as a label.
I guess where I'm coming from is more the idea that PTSD, especially as is identified now or described now, does include behavior problems, especially for youth, like that reckless and risky behavior seeking, at least for me. Maybe that's because I'm way too deep into that literature and that's what I do, but it's just that to me, PTSD is behavior disruptions, and I would advocate for describing that behavior as part of the symptom rather than an additional diagnosis. For me, PTSD encompasses those behaviors, and we could still work with the school and the parents and the kid to help them understand that there is an externalizing component to PTSD, and that is reactive, disruptive behavior, not just oppositional. I guess I worry about the stigmatizing of the ODD, and I think from my perspective, PTSD can also be conceptualized as disruptive.
I mean, I can turn it over to Linda how it played out in this case. I can tell you, generally working not just at IJA, but across the country, that's an enlightened perspective you have. Now, ironically, that's the enlightened perspective we're trying to push, to look at the integration without sometimes trying to dismiss the fact that there are some severe behavioral disruptions in some situations. Like some of the kids I deal with, out in California, they're inside prison for murder. Like, I can talk about trauma, and the system entry might acknowledge and even agree with that. They're not going to permit a complete removal of the behavioral history or manifestations in some of those situations. And it's not just inside detention centers or jails. I also see it out in communities. And I think you're right. I agree with you. That's why we try to come up with an integrated protocol. And I think by context, as Linda was mentioning, there's certain insurance and service world realities that we also can take account of. So if in fact you're in these situations where PTSD is sufficient, not just for you, but for the system you work with, great. There's other situations we might have to continue to use co-occurring. And we do push people to say, when we say co-occurring, we're not joking. We didn't say primary, secondary, we said co-occurring with all the responsibilities that entails of service, as well as, acknowledging where things are coming from. I hope that makes sense. Keep that in mind. We're going to have a whole second half where we're going to open the floor. These are great issues which are being brought up. I know we're running up on some of our first hour time, so I'm going to give the floor back to you, Linda, to keep on.
Okay. Remind me, the break is at what time? Should I do this slide and then we'll see where we are with time?
The break, it was scheduled for 11 because I think that's when people have to go. For those who have to go, so we're just going to give you as much time as you can up to that point.
Okay, got it. Okay, so we'll start going over the course of treatment. And so for those of you that plan to implement Strong Families within the clinic, you'll receive a copy of the manual that goes session by session and explains the different modules. I'll give you all just a brief overview of kind of what each module looks like and each session looked like specifically with Camilla and her family. And so, as I mentioned, we worked with Camilla for a little over 4 months throughout treatment. And generally the sessions with her and her family were 60 to 90 minutes, so a little longer than the standard session, which may be 50 to 60 minutes. I had flexibility in my schedule and I was able to work with this family a little more just due to the complexity of the case and the need for individual sessions with Camilla, individual sessions with her mom or both parents, and then joint sessions with the entire family. So session 1 and 2 focused on introduction to family therapy and treatment planning. During this session, in addition to providing additional psychoeducation about the benefits of family therapy and treatment of trauma and externalizing disorders, we worked with the family to not only identify what would be the focus of treatment, but we wanted to really take a strength-based approach to treatment and identify some of the strengths or areas where Camilla was showing significant kind of satisfactory or positive behavior, and then also some of the strengths within the home and strengths within her parents' behavior. And then session 2 focused on treatment planning. So I showed you all kind of what our treatment goals were and for the process of developing those treatment goals. And in this session, we also talked about some of the key rules and expectations for therapy. So we outlined kind of what Strong Families treatment would look like. We also talked about the importance of parental involvement. And so during this session, we decided that mom would be the primary caretaker just due to her schedule and availability, but then any sessions that dad was available to attend, he would join those as well. And then because of some of the concerns and issues that the family had around community violence during those first 2 sessions, we also did a few different safety mapping exercises in which we helped Camilla and her family to identify different places, situations, and people that would help them in terms of safety mapping or reducing their exposure to community violence. And during that treatment planning session, if you all remember, our, I think, 4th and 5th goals focused on kind of school-based behavior and academic performance. And so during that second meeting, we also had a meeting with Camilla's teacher and school counselor to discuss school-related goals that they would work on and to develop that academic plan. And then sessions 3 through 6 focused on feelings, emotions, and cognitive coping. And so for those of you that attended the TSCBT training, You may be familiar with a lot of those different strategies related to cognitive coping. With Camilla, it was really important to do a lot of different exercises around the cognitive triangle and really helping her to identify or understand the connection between the different thoughts or feelings that she was having, either about mom's health or her interactions with peers or teachers or parents, and then the way that she would respond to her behaviors. One of the things that I want to note about Camilla's family, just in terms of kind of motivation and engagement, throughout the course of treatment, we had different take-home or homework activities related to each session that we would do. And after each session, Camilla's family would always complete the activities. They always brought them into treatment. So even Dad, though he was showing some hesitancy at the beginning of treatment, would often participate in some of those take-home activities. And then in session 5 and 6, we focused on a little more on the thought chart. Using a thought chart and cognitive triangle activity was extremely helpful for Camilla. Throughout those kind of mid sessions, she did a lot of journaling in which she would record, thoughts, feelings, and behaviors throughout the week. And we would talk about those with her parents in session. And then session 6 focused on stress management and cognitive coping. So with Camilla, we did a few different activities using her journal and then kind of art-based activities to develop different coping lists and stress management strategies that she could use. And it was really important for us to create a list of strategies that she could use at home and then also strategies that she could use at school. And what we found was really helpful for her is that the plan that we had for stress management and coping at school is that we shared it with her teachers and counselors so that everyone was in agreement. So one of the things that Camilla included in her plan was being able to take a break and step out of the class when she was really upset. But if she just walked out of class, she would get in trouble. And so we developed a signal for how she could let her teacher know, is it okay if I take a break? And we made sure we had another coping strategy in place for when she wouldn't be able to get up and leave the classroom. And then sessions 7 and 8 focused on family communication, problem solving, and positive interactions. So both mom and dad were present for both of these sessions, and a lot of these sessions focused on looking at the family communication patterns that were happening between Camilla's parents, and then all of them together. And so one of the things that came up during this session, or that we noticed, is that when Dad was present, Camilla was a lot less vocal than when it was just Camilla and Mom. The other thing that we noticed is during the sessions that Dad was present, Mom was actually more vocal about the behaviors that Camilla was showing that she did not approve of. And so it was really interesting to look at, kind of how those dynamics worked within sessions and think about how that played out when they were at home. And so during session 7 and 8, we did a few different role-playing activities where we talked about parenting roles and then different communication styles. And then session 8 was, there was also focus on kind of problem solving, and we include a big section in our module about problem solving and negotiation, and kind of working together to develop different solutions or strategies. And this was one of the sessions when Camilla's dad was very vocal about not negotiating with an 11-year-old kid about behaviors and how things were going to work at home. And so we spent a lot of time talking about the benefits of coming up with different solutions and working together as a family to come up with different strategies, and just how that increased positive behavior as opposed to just telling Camilla to do something, she refusing, and then there was this cycle of misbehavior. Okay, before going to the next slide, one of the things that I wanted to point out that we implemented with Camilla's family during session 8 was the inclusion of family meetings, weekly family meetings at home for them. And we include in the Strong Families Manual a description of those meetings and rules around those meetings in which they're collaborative, helpful, not kind of finger pointing or identifying negative behaviors, but very solution focused. And so family meetings are also really helpful for Camilla and her family because, as I mentioned, Dad was often asleep during the day to get ready for work. And so having those meetings, and they would usually do them on the weekend, was a way for Dad to get caught up on what were some of the behaviors that were happening that were kind of concerning either at home, at school, or what were some of the parenting strategies that we discussed with mom in treatment that he could also work on. And we also had kind of a plan in place for what we called emergency family meetings. So if there were things that came up throughout the week, how they could also have kind of a brief family check-in to work through some of the issues. And that family meeting was anchored on our problem-solving steps that we include within the manual. Okay. So in the next slide, we'll go through the last sessions of treatment. So sessions 9 through 14. First, session 9 focused on child behavior as well as positive parenting. So with this session, we actually, this was a longer session. Both Camilla and both of her parents were present. And I think this session lasted about 2 hours. The first half talking with Camilla, and then we did a session with Camilla, just mom and dad looking at parenting, and then the end of that was a joint session. And so the first half of that session focused on behavior, as I mentioned, and this was one of the I think most important sessions for Camilla and her family, because we were able to tie all of the different skills and strategies that they had worked on in the previous sessions and connect some of the different assessment points that we had used during that initial appointment or intake. And so first, just looking at the behavior piece. So during this session, we reviewed a lot of the different kind of problem behaviors that Camilla's school had identified, what mom and dad had identified, and also what Camilla mentioned that she wanted to work on, and got kind of an assessment of where those behaviors were now and how they would like to work on them. And one of the things that was really important in this session was taking time to identify kind of the different situations that precipitated those behaviors and helping Camilla to identify what were some of the triggers for the behaviors that we were seeing. And as we identified those different situations or triggers, we used some of the coping strategies that Camilla had developed during session 6 to come up with a plan for how she would address each of those situations as they came up. During that separate portion of session 9 where I met with Camilla and Camilla's parents individually, we focused on a lot of different positive parenting skills that we include in the Strong Families Manual around positive family interactions, positive communication, active and reflective listening, and then also the importance of reinforcement of positive behaviors, as opposed to focusing more on the negative behaviors that they were seeing. And during this session, it was really important, again, to highlight the benefits of modifying current parenting strategies or implementing more positive parenting skills without undermining, dad's authority, mom's authority, and the current parenting practices that they were using within the home. Let's see. And then next is session 10 and 11, which was the trauma narrative. So I did an individual session with Camilla during session 10, in which we used a lot of the different journaling strategies and techniques that we had worked on throughout treatment for her to develop a book that was her trauma narrative. And her trauma narrative focused on the different situations that had occurred involving mom's health and her ongoing fear that mom would one day get really sick and then not return from the hospital. So we did her trauma narrative during session 10. In between that, I met individually with mom and dad to kind of prepare them for the information that would be shared within the narrative. And then we did a joint session together for session 11, in which Camilla shared her narrative with her parents. I think that session in between was really important because we were definitely able to kind of gauge what mom and dad's reaction would be to what Camilla had shared. I think one of the things that was really important is that by implementing that family meeting kind of set up earlier on, they were already prepared for kind of how that would be, and being able to have conversations that weren't harmful. And that were very solution focused. And one of the things that Camilla shared in her narrative is that a lot of times her parents often tried to shield her from what was going on with mom's health, which would actually cause her to get more worried or more upset or afraid. So that was really the focus of that 11th session, was talking about the importance of kind of openness and honesty, of course, at a level that was developmentally appropriate for Camilla. And one of the other things that was really helpful is in between session 10 and 11, I also talked with mom. I met with mom and mom's doctor to get an update on mom's health status, so we could have a clear understanding of kind of where things were at with mom, what were the upcoming procedures, and how that would impact the family.
And I may add, the other thing I put in the chat is similar to how you might have heard trauma-focused CBT. We do have an assessment in the beginning. We do think needs to happen in the beginning. And we have the trauma narrative at the end, when people have built up the clinical skills or the clinical orientation to treatment to be able to go through that successfully. But all those modules in between have a flexible sequence based on your case conceptualization.
Mm-hmm.
So for example, if some parent comes in and they are not going to move unless you acknowledge the behavior, you can move the disruptive behavior module up toward the front, get that done, and then figure out the clinically appropriate sequence for the other modules. If so, you would use your clinical judgment about where you feel you need to start with the families while you're still drawing from the manualized content. And I think that's the flexible fidelity that we try to encourage. Also, these are not, as you all know, these are not mutually exclusive modules. So we're not forbidden from talking about behavioral issues, even if we're going through some of the other modules, even sometimes in the assessment. So we're drawing from content that's structured, but you're still using your clinical judgment and consultation about where to use what.
Yeah, that's a good point. And session 9 I think I mentioned, is really a review of all the different strategies. And so a lot of those things in session 9, we tapped into. So module 2 of Strong Families, where we focus on kind of feelings identification and do a lot of work on the cognitive triangle. We focused a lot on those behaviors that we'll recap in session 9. And then module 3, where we look at family communication, we do a lot there on parenting strategies. And so for a lot of our families, they've gotten some of those points there. And then we just do, as we're preparing to kind of wrap up treatment, a focus session on behaviors and parenting. But I would say a lot of those are kind of integrated throughout all the sessions. Let's see, we have 2 areas left. So session 12, I've talked a little about just the academic plan and partnership that we had with the school. As we're preparing to end session, we do one more session that's specifically on school behavior and academic functioning. So this is module 4 of the Strong Families Manual. And here we're really looking at kind of developing a plan going forward for school. And so during this session, we met again with Camilla's teachers and counselors to look at the initial plans that we had set up in some of the earlier sessions to track progress and see how she was doing, and then also set up additional goals that we would like to work on. And then for the last 2 sessions, kind of a treatment review and wrap up. So the purpose of sessions 13 and 14 were to review all of the different skills learned throughout the previous sessions, and then also prepare the family for the completion of treatment. And so you see listed on your slide some of the changes that we saw with Camilla and her family over the course of treatment. So we saw a lot of improvements in Camilla's behavior, and particularly being able to identify the different causes of the kind of stress and anxiety and frustration that she was experiencing, and being able to kind of express her behavior in a more positive way than showing anger or aggression. We also saw a big difference in parenting behaviors, I think with both mom and dad, where they were more willing to compromise with Camilla and come up with solutions that work best for the entire family, as opposed to just telling her what to do, which will usually elicit a negative reaction. One of the things that was really important is I think throughout the course of treatment and as we were wrapping up treatment, is explaining to Camilla's mom and dad that it's not realistic for there to be like this magical fix where Camilla never does any negative behavior. So we talked about the fluctuations that they may see in symptoms, and the importance of being able to maintain a lot of the positive parenting strategies that we discussed throughout the course of treatment to help with positive behavior management. And then we'll go to the last slide here that kind of looks at our treatment progress and follow-up care for Camilla and her family. So here you'll see two graphs. The one on the top is Camilla's self-report of the weekly reactions, emotions, and behaviors. And then the one at the bottom was completed by Camilla's mom. And so for Camilla, the weekly actions, emotions, reactions, behavior scale has several different subscales. For Camilla, we focused on 3 key areas: emotional disturbance, which is the blue line, cognitive behavioral disturbance, which is the orange line, and then PTSD or post-traumatic stress symptoms and arousal, which is the gray line. And so as you can see, this was, as I mentioned, Camilla and her mom completed this 7 times between sessions 2 to 14. And Camilla and her mom were pretty much in agreement regarding the symptoms of emotion dysregulation that we were seeing over the course of treatment. However, Camilla's mom often reported a much higher level of cognitive behavioral or post-traumatic stress symptoms than what Camilla had reported. Overall, we did see kind of an overall reduction and improvement in a lot of the initial symptoms that Camilla was showing at the start of treatment. However, I want to note where we see kind of those spikes in the midpoint of treatment, and those are actually during the times where mom was experiencing significant health-related challenges. So during, I would say, weeks 4 through 8 in particular, mom had several hospitalizations throughout the week, in which Camilla was with another caretaker, and extremely worried about mom's well-being. And so last, just talking about follow-up care. So of course we give families handouts throughout treatment that they can use to have those skills as a reference. Also, we have the Strong Families multifamily group. So a lot of families may do this as a primer or introduction to Strong Families. With Camilla's family, they actually did it at the end of treatment. So they did 2 sessions when we were able to have more families present. And one of the things that Camilla's parents shared is that the multifamily group was really helpful in helping them to see that other families have similar challenges and just how they work through those challenges. Initially, when they started treatment, there was a lot of concerns about Camilla's behavior and the likelihood that they would see a lot of progress within their family. And so it was helpful to have conversations with other parents that had been through treatment and also experienced similar challenges. And then the last thing in terms of follow-up care, it was really important to meet with Camilla's school one last time before ending treatment. And so we updated her academic plan and also worked with the school to make sure she had a 504 plan prior to starting the next school year. And then the last thing that I will share, I think one of the things that's really important with the populations that we tend to work with in our clinics and families that have more complex cases is constantly looking at the different barriers to care or the different challenges that may impede treatment success or treatment planning from the beginning. So we constantly looked at this with Camilla and her family. I think, of course, mom's health was a significant factor that we knew from the beginning would impact treatment, not only because of Camilla's concerns about mom's health, but oftentimes mom would be very tired or very fatigued when she would come to treatment. And so we were able to be a lot more flexible in terms of scheduling of those appointments to make sure mom could still attend. And then also dad's work schedule was a key barrier, especially when you're doing a family-based intervention and there's two parents in the home. A lot of times there was miscommunication about the strategies that we would share. And so I would say after maybe the first few sessions, we sent home additional handouts that mom and Camilla could use to review with dad so that he was up to date about the different strategies that we were working on. And that was really helpful. And then just the last two things that we really worked on with this family, I mentioned kind of dad's role as the authority figure in the home. And so it was really important throughout treatment, again, to kind of remind them of the benefits of treatment and the parenting strategies and behavior management strategies that we were suggesting and how that was to the benefit of the family and not necessarily undermining or saying something negative about the way that they were currently doing things. And so all of those things are really important. We also spent additional time in a lot of our sessions talking about the different cultural factors related to treatment of this family within our clinic. For those of you that will access the manual, you'll see that within each module, there's a section on cultural considerations that talks about the different factors to consider when working with either African-American or Latino families or other cultural groups. And so all of those things were really important in terms of treatment progress.
We hope that this was different than the theoretical didactic, and it was like, let's roll up our sleeves, go hands-on into the cases. And so we'll wrap up with this. Is this relevant, as your comments have shown, as well as our ongoing experiences show? It's very relevant to try to change the lens that we use to address traumatized youth who have experienced behavioral disruptions. And so you look through the newspaper, you see the mass shootings, you see kids trying to recover and still struggling through post-pandemic effects and a lot of other reasons. We want to know how to integrate trauma and behavior into a unified, holistic, and consistent approach.